Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Welcome to today's episode of the Neuromodulation Podcast. Dr. Jumreornvong, who prefers to go by Natty, is a resident physician at Mount Hospital in New York City, practicing across Manhattan, Queens, and the Bronx. She earned her medical degree from the Econ School of Medicine at Mount Sinai and holds a Bachelor of Arts in Human Biology with a focus on health technology policy and management from Stanford University. Dr. Jumreornvong has a diverse career encompassing medicine, technology, media consulting, and writing. She's co-developed an electronic health record, or EHR, software company aimed at improving healthcare in developing countries. Given her multifaceted career, Dr. Jumreornvong is well-positioned to discuss the various career paths available to neuromodulators and how they can contribute to alleviating pain on a global scale, which is her focus. Welcome to the show today.
Thanks for having me.
So your career path spans a breadth of topics, from technology to clinical practice, media. What would you say has been the sort of founding point of how you've woven through all of these different pathways?
So I feel like I'm like a jack of all trade and like a bit of a duck. At first I thought that was like a disadvantage because especially in America, like you're like so pushed towards like being an expert in one thing. But when I was in college, I studied a mix of computer science, a mix of policy, like medicine, and then Mount Sinai, my medical school had this program where they're taking in experimental batch of medical students where you didn't have to do the MCAT and finish all the pre-med requirements. This is to create a new generation of doctor that is more fluid and flexible in your skill sets. So it was the only med school I applied to. They're really good with scholarships for international students. And I just went along with it. And during med school as well, there was an early assurance path for residency. So I did that as well. And that, instead of having to study a lot, which pre-meds tend to, organic chemistry, physics, and now there's even more requirements, I was able to explore my interests and find my own little niche of just mixing and matching things. And it's been a lot of fun. I feel like you can be a doctor and still be a writer, a doctor and who codes, but you can't really be an engineer who also treat patients like that way, or like a writer who's also a doctor, it's just, but as a doctor, you can do more, I think.
But I recall from chatting with you prior that medical school at the start was a bit tough. Can you tell me about that?
Oh, it was so hard. I remember it was like having like a fire hydrant hosing into my mouth and just trying to like memorize everything. I don't know why we have to memorize so much, because now we have like AI and all these like technology to help us, but it did help build like discipline and also like foundational knowledge. But it was a struggle. It was a different type of brain that I had to use, because in computer science, you're more like algorithmic. And in writing too, you're just kind of expressive emotions. But multiple choice exams, that's just like a lot of med school. And growing up in Thailand, we didn't emphasize too much on multiple choice exams. I feel like I've always done better in clinical rotations than in just test taking.
Yeah.
Test taking is really hard. I feel like there's probably more pre-meds out there who would make really good doctors, but they were inhibited because of their test taking ability.
So you started off in a path exploring computer science. What led you to medicine?
My grandma started having a lot of like symptoms in her chronic pain. She had failed back surgeries and just in a lot of pain. And so I was working on the company, I think you mentioned briefly, on electronic health records. And I really like helping the technical aspect of it, connecting engineers to some of the doctors. But being able to, I realized to be able to innovate in medicine, it's really hard to innovate if you're not a doctor yourself, because there's just some things that there's a gap between an engineer and a doctor or like clinicians, that maybe there's a disconnect in communication. Sometimes engineers built technologies without all the input of stakeholders, and there's also a lot of distrust towards the new AI technologies. But if you know a little bit of both, or know a lot of both, then you can integrate that more. So that's why I went back to med school. I thought it'd be kind of fun too. It was really hard, but it was fun.
And tell me about where you ended up landing with your specialization in medical school.
I specialize in physical medicine and rehabilitation. A lot of it's because I like working with people with disabilities. I grew up along the borders in Thailand. There's a lot of landmines in Cambodia too. Some of my family's still there. So a lot of amputees. My grandmother, after her multiple failed back surgeries, also developed like spinal cord injury, chronic pain. So I really wanted to help people with disabilities, and physical medicine and rehab that's kind of like the bread and butter of it. It's like helping improve quality of life and functionality. I'm also a big martial artist. I've grown up doing Muay Thai and then also like brown belt in Brazilian Jiu-Jitsu. So it's just interest in sports medicine too, and pain. So it was a good field for me. Also really flexible hours, allows me to do a lot of my other side quests.
What are some of those?
Side quests? Yeah. The AI and VR technology I'm working on right now, one is on interventional pain training. So teaching trainees around the world, it's available in like 32 languages, how to do a different intervention. It also comes with like AI feedback to multiple choice languages. You're able to juxtapose 3D and 2D images, and hopefully you get better when training that way. A lot of low resource countries do not have access to interventional pain, Thailand being one of them. That's why I was interested in it. It's relatively new field in a lot of the Southeast Asian countries. There are some, but it's not as prevalent. The training's not there yet. So I think it's a good way to expose the trainees and clinicians around the world to this field of neuromodulation, because I believe it could help. It could, if my grandmother had access to the interventional pain procedures, maybe she wouldn't have to suffer from so much pain. That's what I thought when I went into interventional pain. And the other AI VR technology I'm working on is on pain management for patients. So we talked a little bit about this earlier, where using AI text prompts or uploading the images of their loved ones, they can create their own virtual environment, and they can even upload the voice of their loved ones to have a narration of a narrator of, say, like my grandmother. If I'm in a lot of pain, I want to hear her soothing voice. But it also comes with a lot of ethical safeguarding that we have to be responsible for, because there's a lot of ethical concerns about consents, especially if they've already passed on, or like making sure it doesn't leak elsewhere. So that's the technology part. And the other things I'm doing is the media consulting and the writing. I like writing. I've written a few op-eds articles. I also got into screenwriting. I got a scholarship from Sundance, and it's now working with my hospital system to interview trainees and turn their stories into like a encrypted script. That way we can turn it to like an animation. We're now launching like a pilot project. So it's going to be internal first, but eventually we're going to like try to expand it to make it more accessible.
Very cool. So let's start off with exploring the VR side of things. I want to understand, if I am to put on my VR headset, what is this experience like for me, and how is this helping me navigate pain?
Are you talking about from a trainee perspective or a patient perspective?
So let's start with the patient perspective. What's my experience as a patient?
So for your headset, then you can type in the prompt in which you want to be transported to. So if you want to create a beach, which is what I like, and you can just type out, I want this like 3D models to be created, and that way you can like seamlessly create your own VR environment. It's a bit gamified. It's pretty fun to try it out. And then you can also upload the voice of your loved ones or pictures of, say, like your dog or your cat, and you want it to be like in this like 3D space with you as well. And it's also available in multiple languages. When I design technologies, I like to think about global health because that's my background. And then the patient will be transported into a relaxing environment with customizable It can also track your pain level. We're building that on now. So for remote monitoring, so that way we can able to track your not just pain, like VAS pain score, but also disability scale, and to see if your quality of life and functionality improve over time with this technology in adjunct to other pain management tools that we do have.
And how does this solution align with neuromodulation?
I think if you're really into like meditation, it can help. Like there's been a lot of studies out there about how meditation and VR can help with reducing pain. It's affecting your neuroplasticity. I think that's a big role about it. And there are studies too that show that hearing familiar voices in your languages, preferred language, can help with that. So we're just integrating all of that in one technology.
Okay. And what about from a trainee perspective?
For a trainee perspective, because I'm still a trainee, I'm like a third-year resident applying into a pain fellowship. There's so many things to learn. And the more I know about medicine, the more I just feel like I don't know, because new innovations always coming in. And it would be really lucky if I get to like do one case with an attending. That's a really hard case. But if I can just practice beforehand through this safe, realistic environment and low cost tool, and say my preferred language if I live abroad, I think that can help increase accessibility and training. If I wanted to do put a spinal cord stimulator lead in to a patient who's like scoliotic with like a lot of lumbar stenosis, with VR, we can even upload their own like MRI scans turned into MRI models of that patient, and able to then practice on seeing those 3D models specifically on that patient. And the AI aspect is to help reinforce learning through multiple choice questions, and also accessibility by using like the multiple languages context of it.
What do you mean by that? The AI is contributing to generating the content in those languages?
Yes. So similar to the AI voice cloning technology, this one we don't have to clone a voice. We just use whatever libraries out there. But if a patient's or a trainee whose first language is Thai, for example, and they want to learn the content in that language, they can choose to do that as well.
Would you say that the bulk of the patients that you're using these VR and AI solutions with are neuromodulation patients, or is it the breadth of patients that you work with in PM&R?
So I got involved in this VR work through Dr. Jotwani and later on Dr. Young. They're both interventional pain specialists. So that's where our focus is on now.
Okay. And how does neuromodulation fit into your day-to-day practice right now?
Right now, I'm still a resident, so I'm mostly trying to learn everything I can, but I am always trying to build technologies with that in mind, and having seen some cases and performed some assist with some of the spinal cord stimulator practices. It's I think some of the cases are just harder to do because of the spine anatomy, or even the body habitus of very diverse patient population. So having the opportunity to practice the procedure virtually beforehand helps really reinforce my learning and performing it. Also safer for patients. And Dr. Jotwani told me too that he's for some procedures that we haven't done in a while, to be able to practice that procedure virtually before time. It's even as an attending, it's still helpful. In terms of building trust with patients, I live and I'm training in New York City. It's a really diverse patient population. I speak multiple languages, and neuromodulation isn't quite as popular with Asian patients, for example, yet, or patients of color. I think a lot of it's because of fear. It's something still relatively, compared to other pain medications, new for patients of color, and a lot of distrust. There's a long history of patients of color distrusting doctors. So hopefully by incorporating the multiple language options, it's going to help to create foster trust more in diverse immigrant populations.
Amidst all of the interests that you've adopted, why has neuromodulation become one of them?
I believe in pain is so multifaceted, and that some things work better for some patients and some some don't. And I think having all the tools to be able to use would be helpful. Like I'm from Thailand, we do a lot of things for pain, like massage, herbal compress. I was telling you, I also have some like battlefield acupuncture in my ear right now.
Can you show what that looks like?
Oh yeah, it's just like these little pointy sharp things in your ear. And in some ways, I think it's like a little bit like gate control theory too. I have some neck sprain from jiu-jitsu, and like having that sensation changes nearby helps with my pain. And I think like neuromodulation can also play a role there. I think it's better to have more tools than no tools. So it just depends on the patient population and their preference.
Akin to more language access.
Yeah.
So you've done quite a bit of work with advocacy. I'm thinking of your writing right now. Could you tell me a little bit about that journey and how you've been bringing writing into the advocacy work you're doing?
I think before I wasn't that big of an advocate. I think as an Asian person in America, a lot of the times we get fit into this like model minority myth, and that, you just keep your head down, just work on your tech and medicine, and then you'll do well in America. But then during COVID, it was like the pandemic, there was a lot of anti-Asian hate crime. This one guy tried to attack me. He called me a China virus. He actually dragged me across like the street. I asked for help and no one helped me. It was broad daylight. I was able to get away thanks to some of my martial arts background, but I still felt quite shook about it. I wish someone else had like stood up for me, or at least like to help me. So I didn't want other people to feel that way again. I remember before that incident, I never really thought about race. It's almost like I didn't want to think about it. I'm also a gay woman, and so like there's already a lot going on there, and I'm just like, if I just show up and with my clinical expertise, my tech background, eventually like this country must like me, right? But it's not always that way. And so that's why I got more involved with the Asian community. I led a rally of like healthcare workers in Chinatown, and we talked with senators, Congress, and I worked with my hospital to create a Asian equity committee to help raise awareness and also get more funding to also for equity in our hospital systems. And even now, I think I'm with my writing. I wrote a few op-eds about my experience. I got more involved in like the media consulting world too, because then you can help with accuracy of medical TV shows, also raise awareness about diverse like providers in healthcare and physicians. Yeah, I still incorporate AI into a lot of my work. So like I'm doing one research on AI analysis of medical TV shows and just seeing how accurate medical TV shows are, particular to pain, including like neuromodulation, as well as like but how it impacts patients of color.
And we'll link to your different op-eds that you've written in the show notes as well. But I want to call attention to one that you spoke to the impact of being a minority on being a medical school student. Can you comment on that? Did you have any experiences specific to that you want to share?
I think it's interesting with like being, because I remember I wanted to be in a diversity council, and they were like, oh, but you're like an Asian person. Isn't that like overrepresented in medicine? And I like, well, I'm actually Thai. Statistically, there's like 0% of like Thai doctors in America. But then they're also like, oh, wait, you're gay, you can join us. It's almost like oppression Olympics, which is something I don't really like. I think we all are on the same team and we should more be like in it together. And that's what I really like about the NANS Diversity Outreach Pipeline Program. I get to meet many like diverse doctors, and we're all like just trying to reach the same goal, which is to help raise awareness, decrease like health disparities, especially among minorities. My focus is mostly on immigrant population, global health, but really also just any patients. And diversity isn't just in like the color of your skin, it could be your socioeconomic status. Same in a lot of Asian community, there's the largest gap of socioeconomic status. You can be really wealthy, like Asian American, but you can also be really like low income, but still not necessarily getting the same resources and same, you can be a white person who's also really wealthy, and some who are from the rural areas who need more help as well. I think it would be helpful to not think about like us versus them, and we're all just in the same team trying to make everyone's life better.
If you're comfortable sharing, have you run into any hardships with respect to being a minority as a clinician with patients or with fellow providers?
Yeah. I think with patients, sometimes I think the most common one is like they think I'm a nurse or like a PA, which is okay. They're really, I have a lot of friends who are nurses and PAs, and they've done amazing roles, but we all have like different roles in the healthcare system. So I think it would be nice if they know what my role are. Those are okay. I think the ones that are more impactful are the ones where they're saying like racist things, or they can be like sexually inappropriate too. And those, it depends on your attending, if they advocate for you. I've also had really good colleagues who have advocated for me, and I hope to continue doing forward for my mentees as well. As a clinician, there's also like in medical training, sometimes you do see that. It's a lot of it's subconscious bias. I do like doing research, but there was a case where I did the majority of the work. I thought I've communicated well that this was my idea, but the attending, who's like a white man, may have like misunderstood and said that this paper should be by another colleague to lead, who's another white man, even though the topic was on like Asian medicine. It's just, those things exist, and I don't think it comes from like an ill place. I'm an optimist in that sense. I think a lot of it's like education and not knowing, and things are much better once you like communicate. I think it helps me heal more too, especially with that Asian hate crime. It actually happened right in front of my hospital. And this was during COVID when everyone was calling us like healthcare heroes. So to cope with that, I was thinking, I think maybe the person who attacked me, maybe he just was uneducated, about this topic. Maybe he's really scared. I think that helps me move on better, just to know that like I believe in the best of people, and just if we keep showing up, being good to others, hopefully that energy is returned.
Well, and I want to say that I appreciate the vulnerability and generosity of spirit to share this story, because I understand it's certainly not easy. Would you say that you're still navigating the impact of that?
Yes, I'm still in therapy. I think we should talk more about that too in medicine, about being open about like vulnerability and navigating this. And I've had really good, like my program director, Dr. Escalon, is so good. And we have like a wellness director in my program, Dr. Ricabono. We just have like almost like a week, like monthly check-in. We have wellness retreats. Our program's really open about that. I'm also the well-being co-chair like for the trainees at my Mount Sinai healthcare systems. And my hope is to be able to talk about these issues, because then people can come forward more and ask for help. We have a lot of physician suicides in medicine, especially post-COVID and beyond. So I think it's just something that as long as they feel like they're not alone, it's good.
Well, I want to pivot to think about or to discuss the media consulting work that you've done. Is there anything else on the note of diversity and the experience of being a minority that feels important to share while we're on this topic?
I think some of the media work I've done, some of the media analysis work that showed that in the shows and the reality maybe not always accurate. Like in Grey's Anatomy, for example, it's like a world where like all the top like leaders are women and women of color, people of color, but in reality, leaderships are still majority like white men. But I don't think it's like necessarily like a harmful thing. I think it's just as long as you're like supportive and know that we're also trying to help like patients of color. Diversity in healthcare patients tend to connect more when they see a provider that looks more like them and share their experience. But I think there's many like well-meaning physicians of like diverse background that really want to do that. And as long as we keep advocating, that's like media consulting, that we want to advocate for those in need and with diverse background, I think we're hopefully just going to the right direction.
Well, let's back up a step for anybody who might not know. Can you explain what media consulting is?
Oh, yeah. It's just like TV shows sometimes like send scripts and then you're just saying whether or not it's like accurate or not. And then also asking them and also telling them your recommendations.
Basically, to ensure that medicine is effectively articulated in the content.
We best
demonstrated
as we best can. A lot of times the accuracy is minimized because of like they want to heighten the drama. And growing up, I watched Grey's Anatomy too, so I was just like, I would love to be a doctor. And then I like med school residency is not like Grey's Anatomy, so it's like, oh, okay, yeah. And just also be okay with it not being perfect, just kind of like how it is in medicine.
Can you speak to any particular episodes, like an example of content that you've reviewed and then submitted back to the show?
Oh, I don't think I can particularly mention that, but there are some that I think was more like, if it's like pain related, I think they try to like make it a little bit more accurate if it's pertinent to the topic. But if it's like the dramatization, it's just like they do whatever. Yeah.
What are some of the elements that you're looking to create as much accuracy in?
That's why I'm working on that, like the miniseries with the animations in my hospital, because that's more based on the interviews of trainees themselves rather than like writers who think that trainees might be feeling this way, just to come up with a script based on their own experience and get the consent and also approval of like the people involved in the stories, while maintaining anonymity to like make sure that they don't get retaliated by sharing their stories.
Yeah, I was reflecting on an earlier conversation we'd had where you spoke about opioid management and how that might be reflected in a television series, for example, across lines of gender. So could you talk a little bit more about that and what sorts of elements of medicine are, I guess, you're looking to facilitate accuracy around?
I think some TV shows, like I was analyzing some episodes of like Grey's Anatomy, and I think they did a really good job because Shonda Rhimes is a minority, and she it's almost like maybe it's like subconscious, but a lot of the patients of color there tend to have like better outcomes than say like in other shows that are more like white male run. And I think like maybe it's all subconscious, or we just need more data of like the analysis as well to see if it's accurate. But in some ways, if you're like a minority and you see a TV show and you see that, oh, look at that, like Black patient and they're doing well, you feel a little bit more optimistic. Versus duality may not be the case. But for me, when I was growing up, I saw Christina Yang became a cool doctor, and I was like, that's really cool. Or like, I think it was the first time I saw queer representation as well on TV show, and I was just like, oh, that's really cool. I can be like that, you know? So I think it at least normalize things more.
Do you have any thoughts about accessibility for neuromodulation across different socioeconomic statuses, races, etc.?
I was thinking about this too, about like whenever I'm like rotating in interventional pain clinics, that most of the patients who consented for neuromodulation technologies tend to be higher socioeconomic status, and also like from like mostly like white patients I see. I think it's a mix of like distrust towards this technology of neuromodulation and also lack of access to education about it. I was telling my parents about this like spinal cord stimulators, and they're like, wait, so that's kind of scary. Like something, it's just like a medical device foreign into my body. Am I going to turn into a robot or something? It's just kind of like, educating too about what it is. A lot of it's also access, whether or not it's right now with like the reimbursements, to making sure educating patients about trying to navigate that areas. So I think it's mostly like, it's a combination of not knowing what it is and also accessibilities in terms of income. And I don't think it's particularly like an issue with just neuromodulations. It's also an issue across broad. Like, when I was an intern, I was working in a transplant committee, like the rotation, and we were deciding who should get which organs. And a lot of times it's like, oh, this person, she's like a single woman, she's an immigrant, she's homeless, she can't take care of this resources. And so a project I'm working on with Dr. Young at Brigham and also with the people at MIT is creating like a predictive models that are more transparent to be able to say exactly why we recommend certain treatments, not just a black box of AI telling you this is our recommendation, but actually specifically say like, if they're going to deny, like for example, if an insurance is going to deny you of this treatment, then they would have to specify why. That's not because of a demographic bias, for example. That's not because like of your race or your age or your gender or socioeconomic status, but have like a more clinical reasoning behind it. I think at least that's going to make neuromodulation more fair.
I'm thinking back on you mentioning that there aren't many doctors from Thailand in America. Do you think that patients having the opportunity to connect with clinicians that have a background that's akin to theirs makes a difference? Or is it more about, basically, do you think who's delivering the message matters more or getting the information to people?
I think it's a combination of both. I think it's so innate in our human nature to like connect with someone who is like the in-group versus out-group, and it's like connecting with someone who reminds you of yourself. I have broad, diverse friends, but I notice like my closest friends tend to have more immigrant background. Doesn't matter if you're Black, Latino, or Asian, but if they're also an immigrant, I tend to connect more with them. And so similar to providers, I think like I tend to go for physicians with more diverse background because I think I connect better with them. But if they also have the knowledge to back, like I think that's even better.
Well, and you shared a little bit of your immigration journey with me, but I think it's an important layer to consider. Going to medical school is already a lot. Becoming a clinician is a lot. Is there anything that you would like to share about also being an immigrant and a clinician in the States?
Oh, there's so many visa hurdles and getting scholarship for medical school too is hard. A lot of medical schools wanted you to pay 4 years up front. Thankfully, my medical school, Mount Sinai, was really good about the scholarships for international students, DACA students. And then afterwards, there's also visa, I think, which H-1B visa. Meanwhile, I have an attending mentor I know who was on a J-1 visa. Even though she married an American, she had to like go back to her country for a few years, even though she had like kids that are Americans. So being away from her nuclear family was difficult for her. And I'm applying for fellowship right now. I'm probably going to have to move outside of New York so I can like find a fellowship spot. So it's just navigating the hurdles and then trying to get a green card. There's this whole tier of immigrants, and it's just a little bit dehumanizing at times, but you're trying to navigate it. There's extraordinarily alien, there's exceptional alien, highly skilled alien, and you just gotta be one of the aliens. Yeah. And you have to like publish a lot. You have to do many things to hopefully prove your worth in America.
Do you have any guidance that you offer to people that are navigating that journey other than publications?
Get involved with societies. A lot of times you connect with other physicians who also navigated that before they really give good advice. Get good letters of recommendations from the people like physician leaders across, because I think they want a letter that's not just from your institution. So being able to connect to these physicians at a societies was helpful. If you are also a judge of other people's work, so being like an editor, peer reviewer also helps.
So we were chatting earlier, you talked a bit about being an optimist, but also a bit of a pessimist regarding artificial intelligence. You work with it a good bit, and we've talked about the experience of being a minority. What do you think about bias in AI, and how are you going about, I guess, controlling for that in what you're building with AI?
Yeah, a lot of the data we have right now are majority like higher income white men. And we've had this research in pain medicine too, showcasing that sometimes like when a woman with like pain came to the emergency room, they're more likely to think it's like anxiety, like the doctor thinks it's anxiety versus like a heart attack, for example. So if we are able to recruit more diverse data, both like female participants and also like patients of color, then we'll just have a more accurate data. That's why I'm trying for my clinical trial sites and with my AI VR work, I make it a point. I was talking to some of my collaborators, like, let's get a site in Queens, let's get a site at Bronx, like, because then we can have more diverse patient population that way. And some of the particularly like I'm excited about is using, I can't talk too much about this because it's like still like in the development, but our aim is to use some more transparent like predictive models to be able to showcase like exactly why we recommend certain pain treatments and also reduce demographic biases. And one of the things I'm doing is studying different AI models that are generated like 3D modeling, because I think that's so powerful to be able to use like AI generated 3D models to do like pathology analysis of like, say, like lumbar stenosis, cancer models, and just being able to do it rapidly. You can really streamline the process of like clinical trials and prototypes development. So we're just, the study that I'm doing is just analyzing all the AI models and see which one's the most accurate, efficient, cost effective as well. That way we can hopefully replicate models more reliably and efficiently. Because some models, I asked an AI model to make me a lumbar stenosis and they made me a chair. I don't want a chair. So,
can you talk about the mechanism that you're using or the parameters you're using to assess what a good model is?
So we have like a reviewer too, who's like a human reviewer, like physicians who's like a third party, and they would just grade the AI models based on accuracy of compared to like a actual lumbar stenosis models, or reliability, how they can like replicate it accurately across like times, and cost effectiveness and time as well. Yeah.
Well, I really appreciate you being here. Really fascinating conversation, and hopefully we can have you back at some point.
Yeah, thanks for having me.